This presentation was created by Dr. Donald Juravich from the University of North Dakota Department of Geriatrics. This presentation is one of 2 micro-lecture modules on the geriatric 4 M's of medications. This program is supported by HRSA through the Geriatric Workforce Enhancement Program Initiative. The goals of this presentation are to consider the risk factors that are specific to older adults. We want to reinforce the concept that polypharmacy is hazardous and unsafe, and we would like to deal with or understand what the barriers are to deprescription, both from a health system's point of view and from the patient's perspective. It's important to understand why we practice the 4 M's as a set. One of the 4 M's interfaces with the other 3. Medications might influence what matters, mobility with the risk of falls with certain medications, and then also mentation, knowing that medications can cause delirium and memory loss. New data suggests that long-term use of PPIs might be associated with dementia. It's important to consider the interface between each of the 4 M's. When evaluating medications, we need to keep in mind the Hippocrates model, do no harm. We always want to be on the left side of this diagram, so we're maximizing benefit and reducing risk. Some of our best interventions still may lead to harm. For example, if we add an additional SSRI for treating depression, we also increase the risk of falls. There's always a risk-benefit ratio that we need to be mindful of. There are some conundrums in deprescribing. Part of it is that we have a population that's living longer, while at the same time the trained workforce in geriatrics is static. There are fewer geriatricians now than 10 years ago. There is also the consideration of drug safety amongst increasingly vulnerable older adults. These medications continue, and as the older adult has a functional decline or a decline in renal function, the medications are not adjusted on a regular basis. We don't have perfect deprescribing guidance. The other point is many clinical trials don't include older adults. We know that pharmaceutical industries don't have an incentive for studying vulnerable or frail older adults. And importantly, there really are no robust guidelines for how to handle medications when there are multiple chronic conditions. So, when people have 5 chronic conditions, and you have maybe 1 or 1.5 medications per condition on average, you have already entered the realm of polypharmacy. There's assuredly some drug interactions that occur due to having to treat these multiple chronic conditions. Here's a good example of study enrollment. You can see that the 75 and older age group had very low representation in an oncology study for this clinical trial compared to a younger population. This reinforces the concept that we don't have a lot of strong evidence about side effects or certain medications. That's one of the issues even with the new Alzheimer's medication called lecanemab, where the average age was much younger than you would expect to see in clinical practice. We have to understand that older adults range from quite healthy, robust individuals at all age groups to a certain percentage of frail and vulnerable older adults. As they approach that frailty time period, the older adult becomes increasingly vulnerable to various stressors. Those stressors might include medication burden and medication side effects. They become more intense as a result of the functional decline that people experience. This is true in the final 2 to 3 years of life. People become intensely vulnerable to different side effects. That's why we see a lot of delirium in hospitalized patients because of their medication baseline, which includes 1 or more anticholinergics. It's important to be mindful of the dreaded and somewhat insidious adverse drug effects. They are under-recognized by multiple research studies. A lot of times, the symptoms are attributed to disease rather than medication side effects. Many times, this leads to additional treatments to treat the symptoms of drug side effects, which leads to a vicious cycle, similar to a dog chasing its tail. It's best to consider what the adverse drug event might be, and the risk factors. Those who are over 85 are more susceptible to polypharmacy. More than 6 medications have 100% certainty of having some type of drug interaction. Those who have low kidney function, particularly those in stage 3 and 4 chronic kidney disease. We can't underestimate the issue of multiple prescribers. One study demonstrated that there were as many specialist visits as there were primary care visits in an ambulatory care clinical practice. Low BMI and frailty are predispositions to drug side effects, as well as multiple chronic conditions. With blind adherence to guidelines, we know that spironolactone is not a good medication with heart failure for about a third of older adults, mainly because of reduced renal function, and it causes hyperemia. They are also well-known high-risk medications, which is why we put so much emphasis on avoidance of anticholinergics, such as muscle relaxants and first-generation antihistamines. Here is an example of research that demonstrates how side effects escalate with a number of medications. You can see in the middle the probability of a drug interaction increases from 50%. This is a pretty high rate, especially when you have 5 to 9 medications, and up to 100% interaction with those on around 20 or more medications. You can see what the bad outcomes are. Death is a potential outcome, which could be from delirium, which carries a certain mortality rate. Falls result in 10% of the time of serious injury, which there's a percent of mortality associated with that, and disability resulting either from falls or cognitive changes. It's interesting to note that the induction of or the promotion of frailty, as a result of polypharmacy, is clearly a reversible element for avoiding frailty. With medical complexity, we get into this red zone of sometimes inappropriate medications. The number of medications makes a difference. There is also the concept of tight adherence to disease control. While the guidelines for hemoglobin A1C have loosened up for diabetes, there are still individuals who seek tight control of their blood sugars. There's always that question of inducing hypoglycemia, and there are other examples where following best practice guidelines may not always be in the older adult's best interest. We need to consider some of the barriers to deprescribing. For a busy clinical practice, there's not always enough time. Also, with continuing medical education, the whole issue of deprescribing doesn't always come up on the radar, and so there may not be opportunities to reinforce the concept or to do a deeper dive into the process. Notice the third point about the patient insistent on taking a medication. To illustrate this, a doctor tries to deprescribe an antipsychotic for an older adult in a long-term care facility. The patient explains that his psychiatrist prescribed that medication for him 30 years ago, and he is still taking the medication. The patient was resistant to deprescribing the medication because he felt his health was dependent on it. Another barrier is that it's a challenge to communicate with other prescribers. Another problem is the issue of who has the prescriptive authority. It's important to understand that we do have ownership, particularly in primary care, for those medications. If it does require a consultation, a message, a phone call, or whatever communication to reassure that your deprescription process makes sense with the consultant, then we're obligated to promote that approach. Here is a list for deprescription blockades. This reinforces the issue of how the prescribers may be reticent to reduce medications. Side effects are a barrier too. You might deprescribe a PPI, and then a couple of weeks later, the individual shows up in the emergency room with an acute GI bleed. It makes you wonder about cause and effect, despite the fact that there was no clear evidence. For instance, for using the PPI, other than for perhaps a history of reflux that had resolved. This is a good example of what the provider fears and the viewpoint of the patient. They view that medication as something given to them by an expert, and now they don't understand why it's being taken away from them and why you feel qualified to do so. In summary, we want to recognize the fact that aging is a clear risk factor for medication-induced adverse events. We know that individuals who are on 5, 6, or 7 more medications, that there's a strong likelihood of drug interactions that we need to be mindful of. Part of the problem with deprescribing is this fragmentation of the system and episodic nature that reinforces the concept that with each clinical encounter, when we practice the 4Ms, we include a medication review of not only the medicines that we prescribe, but also those that the older adult may be taking as over-the-counter or using medications of someone else, either a spouse or friend. We need to be mindful of the crossover between providers and the barriers to deprescribing and enhancing our communication to solve that. Also, we need to consider trying to break down the psychological barriers to deprescribing that exists with patients who have been long-standing users of a particular medication. That's particularly true with opioids and benzodiazepine. Also, consider what the medication impact is on the other 4Ms. Is it really making a difference in what matters to the older adult? Is that statin in an 88-year-old increasing the medication burden and making their life more difficult because they're taking so many medications? Perhaps that's an opportunity to ask if deprescribing that medication might make a difference and simplify the regimen for the older adult. Thank you for listening to this presentation. Up next is part 2 of this series.